Thank you very much. Good morning, everyone. Okay, so I'm going to spend the next 15 minutes talking about a slightly different strategy, but I'll go back to my training. So this is how we take lung cancer out when I was a trainee in surgery. So we used to do big operations and we take the whole lobe out, as you saw in the last operation. And then when I became a specialist trainee, we do this multiportal VATS operation. So we had to do keyhole operation, but you need several holes. So multiportal VATS operation. It was so unusual that even when I was, when I was trainee, I had to go and find a VATS fellowship to learn this. And then come 10 years later, oh, forget 3 holes. Let's do it through 1 hole. We do uniportal, as a professor said earlier. Now, what do you think is going to happen this decade? Do you think with all the AI, well, the AI equivalent for a procedure is a robot. So do you think it's a multi-port robot surgery? Do you think you squeeze all the ports into 1 port and have multi-port robot through a uniport? Do you think it is a uniportal robot, a clever robot that could do everything through 1 hole? Or forget about the hole. Let's go through natural orifice. I'll let you think about that. So the endoscopic route to the lung is a little bit late in the development compared to endoscopy for the bowel, probably because of 2 reasons. One is it's a bit like coming to Bangkok, millions of roads. How do you know which road to go down? And the second problem is each road gets narrower and narrower and narrower. So it's like driving a truck down these roads and you get stuck in an alleyway. So the technology that needs to be developed to get to the periphery of the lung doesn't come till about 10 years ago with this navigation bronchoscopy. However, the uptake has been rather slow because the accuracy of this technique is only about 60%. So 1 in 3 cases you spend money on doing it is a futile procedure, so it's not really that cost effective. And this is illustrated in this case that I often show. You can see because my catheter is passive, I can't control the tip. I sometimes find myself circling around the lesion. I'm in front of it, behind it, above it, below it, everything but, because one thing I can't do is to bend it towards the lesion. And my anesthetist who watched me suffer doing this procedure says it's a bit like you playing snooker with a rope, throwing a rope and hoping it would hit the ball. But the last few years sees the advent of robots, AI robots. And so the robotic catheter does this. You can now flex this catheter. You can see the range of movement it has. But not only that, once it's moved into a certain position, you can hold it still. And it will allow you to have a very fixed operating environment. The other thing that's advanced is now you've got a camera. You have a camera and you can go down and down. You can see all the branches. Look, you can go the carina, carino, carina, carino. So this solves the other problem because you've now got built-in transformation. So it doesn't matter whether the lung is collapsed, it's in full inspiration. You think the target is there and it moves with breathing. But not if your path, your rope moves with it, because suddenly you don't need to worry about the 3-dimensional position of the lesion, because if you know the bronchial address, left, left, right, left, you know left, left, right, left, it's there in the inspiration or expiration. This is the level of precision. You can see if I reach the nodule here in my navigation, I used to be happy. I used to be, opening the champagne now. I've got there. But now with the option of precision, nah, this is not good enough. Let's move it. This is sagittal, so I want to move it a bit anteriorly, move it anteriorly, almost there, still not perfect. I want to be center strike. So there we go. We move it a little bit more and we throw the needle out. The top right, you can see a cross section. The needle is right through the middle of the nodule. Does it work, really? So actually, the diagnostic yield with robotic bronchoscopy, when combined with the cone beam CT image you saw earlier, has a diagnostic yield now in the mid-90s. So it's reached the level of CT-guided biopsy and so on. So now we have a technique which is not an effective one in the 3 times, but now we can reach and get tissue most of the time. So our early experience, so we actually did a prospective trial to get data for Europe, and our early diagnostic yield for the first 250 cases, 88% immediate diagnosis of malignancy or confirmed negative. But the true diagnostic yield, of course, also includes the false negatives, which you need to wait for time or you need to resect to confirm is negative. And it's usually about half of the negative. So that would take us to the low or mid 90s. It's very safe. Compared to percutaneous, the pneumothorax rate is 0.8%. It's less than 1%, so most patients go home a couple of hours later. Most important thing, you can do more with less. It's very easy to do. So first of all, the procedure time is, the learning curve is short. So within 30 cases, your procedure time is halved. Now the procedure is about 20 minutes. And it's faster than navigation bronchoscopy. So my managers love it. My managers say, oh, you can do 8 cases rather than 6 cases a day. For them, it's more ka-ching. But the other thing is, it's so easy to do that you don't ever need to have held a bronchoscope to do it. There's only 2 controls. You either go forwards or backwards, and you turn your head around. And if you could ride a bike, you can do it. And this is one of the problems. It was impossible to teach navigation bronchoscopy because how you twist the catheter to try to aim at something is almost an intuitive thing you can't teach. Whereas here, it suddenly breaks down into a very logical thing, and we can reach it easily. And with this level of precision, the previous paradigm is the larger the target, the more likely you get a diagnosis. Because the larger the bullseye, the more likely your dart will hit it. With this level of precision, size is no longer a criteria for the accuracy of the procedure. It now means that you can get sub-centimeter lesions with as good accuracy as lesions that are over a centimeter. So for me, this is a game changer about a bronchoscopic approach. You can even do challenging key lesions. So this is a patient who had a myocardial infarction and then had a CT at the time, and you can see there's a lesion right there where the arrow is. It's right next to pericardium, so this lesion is doing this with every heartbeat. And on the bottom left, you can see that it's also on the diaphragm, so it's doing this and going up and down and up and down. And it's not a nice place to stick a needle in because you're doing something that's close to moving. However, as I explained to you, if you go down the bronchus and you know where the left, left, right, left address is, it doesn't matter where it is because the bronchus will move with the lesion. So here we go. So on the left is the computer telling me where to go, and on the right is what I'm looking at. You can see there's a big hole at the top and a hole with the division left and right on the bottom. It tells me to go left, and so I go left. And it tells me the lesion is just behind that carina on the left. So it doesn't matter if it tells me on the CT plan it's 20 centimeters away. On the right, you can see it says 20. I know it must be there. In fact, I can see a little bulge there. So we go there, we park our catheter and stick the needle in. And then we've got a diagnosis. The thing is, in this position, it's easier to do as the bronchoscopic approach. Because when you use a bronchoscope, you're pointing away from the heart because all your things are always radiating away. So it's a lot safer than to stick it out from the outside in and aim for that. And that's another security about the bronchoscopic approach. And we got the tissue, and I love this. You know, I spent all this effort. My pants are going brown, and I'm getting palpitations doing this procedure. And the pathologist says, multiple tiny pieces of tissue. After all that effort, it actually is not that bad. It's 8 millimeter by 8 millimeter. Shows there's enough tissue to get a diagnosis and moleculars. So with this level of precision, the question is, if you could reach it, could you treat it? And I use this case to illustrate where the power of this procedure is. So this is a 70, some of you might have heard this, because this is a lady that's been around for a while. She's 74, she's got combined COPD and ILD and still smoking and enjoying her cigarettes. She is not very fit. She can only walk 50 meters because of breathlessness. Her oxygen level is 93 at rest. She's got poor lung function, and she's already got cor pulmonale. So her right heart's finding a struggle to push the blood through the lungs because there's not much lung left, and she's got a high pressure in her pulmonary hypertension. There's her lung. You can see all the pulmonary fibrosis, and you can see a lesion at the base of the left lung. As you expect, mediastinal nodes are hot in patients with ILD, and the benefit of coming in through the airway is that you could biopsy the lesion and you can sample the lymph nodes at the same time, so you get staging information. And as you expect, the tumor is cancerous, but the lymph nodes are reactive. So she went on to have an ablation because she's got poor lung function, she's not fit for surgery, and the radiotherapist doesn't like giving radiotherapy to patients who've got pulmonary fibrosis because it accelerates the pulmonary fibrosis. So we're told she has no option. So we've been there before, so we said, well, do you want the same procedure, but this time I'll burn the tumor, right? So we ablated the lesion, and this is her imaging 1 month after the procedure, you can see the ablation zone is a consolidated area, and over 1 year, 2 years, 3 years, the lesion gradually shrinks, the scar gradually shrinks away. She finally died 14 months later because of a ILD exacerbation with right heart failure, but at the time, there's no evidence of recurrence. And for a patient like this, the important thing for her is she has to maintain her minimal quality of life. You don't want to knock her back. You don't want to knock her back for 6 months. You don't want to knock her back with breathlessness for the next 4 years. So what can we ablate? Well, primary lung cancer, I've shown you patients who are medically inoperable. That's one of the salvage options for them. But also metastatic disease, arguably there's a stronger argument to ablate oligometastatic disease before there's firm evidence for it, because you are giving them local control only and not systemic control. And in a situation like this, where there are multiple mets in the same lobe, where you can end up resecting too much lung for the metastasis, it's a good idea to ablate to try to preserve that lobe. It's also suitable for challenging cases like radiotherapy. So this patient had radiotherapy, and you can see there's a lesion growing in it. It's not easy to go in surgically, and you can't have any more radiotherapy there because the lifetime doses there has been maxed out. And here we ablated it. You can see the ablation zone. The first appearance of the ablation zone can look quite frightening with a big cavity and a big hole, but that resolves quite quickly. Cavitating lesions happens quite commonly. Can be quite alarming. The radiology departments ring you and say, do you know what's happening? Actually, it's fine. Recurrence on surgical staple lines, very challenging, because there you could see the staple line and the little nodule there. Is this nodule a granuloma, or is it a recurrence? And then if it is a recurrence, it's not easy to resect the previous staple line. And so what we can do is we can navigate how to do it. We biopsy, confirm it's malignant, and then ablate it. Here you can see the ablation zone. You can just see the staple line going through it at 6 o'clock. Patient who ablation can also recur. So this patient had a colorectal metastasis ablated. You can see the ablation zone shrinking. And then it should shrink all the time. But if something is growing, like this ear at 11 o'clock, there's something suspicious there. It's not supposed to grow. So you can go there and you can biopsy it and then re-ablate it. And here you can see the ablation zone surrounding that Mickey Mouse ear. And then on the follow-up, it doesn't grow back and it's PET negative. The other advantage of having an endoscopic approach is you don't need to worry about pneumothorax and bilateral chest pain. The patient's so painful they can't breathe. So what you can do is you can go in, you can go to both sides without needing to worry about this. So you can see there's this patient with 2 metastases. In one sitting, they can have both sides ablated endobronchially, and you get 2 nice ablation zones there. But if you've only got a hammer, everything is a nail. Sometimes maybe ablation is not the right thing to do, and surgery, other times surgery is challenging. In this patient with colorectal metastasis, there's 1 metastasis right in the middle of the right upper lobe, which is between 3 segments. This is not an easy one to resect because you'll have to resect quite a lot of parenchyma for a tiny nodule. The other one on the other side is right next to the fissure. It's close to the surface of the lung, so you can feel it, lift it up, and snip it. So this one, probably better not to resect. That one, you don't want to poke a hole in the pleura, probably better to do an ablation. So you can do it in the same sitting, bilateral. You ablate this side, flip the patient over, and wedge the other one out. And I like this slide because you could see both the ablation zone and the staple line on the same slice. Does it work? Well, we did the first trial of the 30 patients to show that this procedure is safe. And since then, there's been an explosion of interest in this procedure by the number of publications in this area. So this is our 5-year results we presented 2 years ago. At that time, we've got 100 nodules, about 200 now. You see a third of them are lung cancer, the other are metastasis. We do a 10 of them, 1/10 is multiple and 1/10 are combined with surgery. We showed that the grade 3 complication rate, that complication rates that needs treatment or admission to hospital is only 8%, is similar to radiotherapy and substantially lower than surgery, which is about 30 to 40%. And we showed that actually the local recurrence rate is very, very acceptable at 18%. The question is, Well, 18%. I mean, I should be happy with 18%. That's pretty much rivaling SBRT, but I'm arguing that we could do better. If you fire more accurately, you can fire directly at the nodule. So why is it important? Because if you're in the center of the nodule, you ablate, you heat round the whole tumor. The heat has nowhere to go but into the tumor, and you only need a small ablation zone. However, if your technique is not very accurate, you sometimes end up next to the lesion, and you have to make the ablation zone a bit bigger to catch it. Or worse, you are not even touching it, and you're hoping your ablation zone kind of catches it. And this is what happens. The further you are, the larger the ablation zone. So if you're just 1 centimeter out, then your ablation zone needs to be more than 4 times. Now, is your catheter able to heat up this same volume to the same temperature? Probably not. And also, is it able to heat the tumor with a gap in between of air? That's also another uncertain question. And I argue that when you do the ablation and you end up in optimal positions, that's when you get recurrence. So with the robot, you can now get to be center strike. And so maybe this is the answer. So this patient had a previous right lobe lobectomy 10 years ago, and then had a left upper lobe resection, wedge resection 5 years ago, and now developed this 5mm nodule here. And so we try our robot. So first of all, it is possible to pin this nodule, 5mm nodule with a robot, right through center strike, and we get a diagnosis. It is an adenocarcinoma. And then we put our ablation catheter. You see, here's the ablation catheter docked into robot, and we can drive this 3mm catheter into a 5mm lesion and burn. So this is what happens on the day after. You could see the nodule, you can see the shadow of the catheter, where the catheter was, the nodule, and the surrounding ablation zone completely covering that lesion. So you can now treat very, very small nodules. You're now allowed to ask the question, is this 5mm nodule malignant or not? Rather than having to say, oh, shall we repeat the biopsy? Because the technique is available if you want it. Of course, the next question is, oh, this is all very exciting, but I'm a surgeon. I'm asking the same question. Am I going to lose my job? So in this group in China asked the question, does percutaneous ablation, is it as good as surgery? And they showed that actually the 5-year survival rate in their single institution unit is the same. So it is as good as. The only difference is, as you would expect, ablation patients have more pneumothorax and surgical patients have more respiratory failure because it's a more invasive procedure. So the group in Guangzhou then did a multi-center propensity study with 1,500 patients, and they reproduced these results. And they say patients with less than 3 centimeters, it is as good as a lobectomy. And the complication rates, well, you expect again, pneumothorax is higher and respiratory failure is higher for the lobectomy group. So I posit this question. If we know that for small nodules, ablation is very effective, and we know that surgery, segmentectomy is a bit challenging, do you think your patient, which one would your patient choose? I'm not asking which one would the surgeon choose, because I know which one I'd choose, because when I'm doing the procedure, a robotic resection, you get this zen feeling, it feels good. But I'm asking you, what does the patient want? So there's a lot of interest in this. And so with a catheter, you can put anything in, and there's been an explosion of interest. So in the last couple of years, we've seen other energies put in, RFA, laser directly burning the tissue, or photodynamic therapy using light to activate tumor, even cryoablation. In China, they've developed a catheter that can cool. This 3mm catheter can cool to minus 140 degrees and freeze a 4-centimeter ice ball in the tumor. It's a very exciting area. We've also talked about this pulse electric field, where you just punch holes in the tumor and try to get it to release antigens. And they know that tumors that have been pulse electrified has formed these immune centers in it. That is like a procedural immunotherapy. And they've even tried it in stage 4 disease. Suddenly, you're not just treating stage 1 disease. The whole of the disease group is now within the reach of the bronchoscopic therapy. And of course, we talked about this. Driving through a road in Bangkok, you can use a car or you can use a self-drive car. And with a bronchial tree, which is just roads turning left and right and turning left and right, it's very easy to automate. And you can see these catheters are already developed that would self-hone into tiny targets. So in the future, all we need to do is press the on button. So in summary, I've overrun a bit, I apologize. So the bronchoscopic approach is the next no port approach, which has already happened in GI, in urology, and hepatobiliary. Ablation using this is safe and effective even when I didn't have suboptimal positioning, and the robot allows me to be more accurate and allows me to get center strike and be more precise with my energy delivery. It is also suitable for patients who are not suitable for other procedures at the moment. Thank you.